Okay, so we're going to talk about legal and ethical issues in nursing. There's a lot of the stuff you had back in Nursing 100 with Ed in terms of things like informed consent and that, but I'm also going to talk a little bit more about things like malpractice and ways that you can get sued and or lose your license. So it's really uplifting conversation that we're going to have this evening. So just a quick review on informed consent. What does that mean? They agree to allow something to happen, a procedure, some sort of like a surgery or something like that. But what does that disclose to them? What does the informed consent have on it, in terms of information for the patient? The risks involved. What else? Right, that it was explained, what was going to be done. The doctor, explains the procedure in hopefully language that the patient can understand, that they understand the risks and benefits of having the procedure. What else might it disclose? What's that? What to expect in terms of, and that's part of, explaining the procedure. But it will also sometimes tell you what some of the alternatives are, what the risks are of not having the procedure done might be on that informed consent, to make sure that the patient understands the necessity of having that particular procedure. For a patient to sign an informed consent, what is their criteria? What do they have to be? They have to be alert and oriented, they have to be mentally competent. What else? Over 18 or an emancipated minor. And the consent has to be voluntary. So, what's that? It can't be forced. Right, it can't be forced. It can't be coerced. And sometimes you'll have a conversation with patients and you may hear something like, well, I really don't want to have this done. I'm 90 years old. Why should I bother to have this done? But my family's really pushing for me to have it done, or the doctor is really pushing me. And so if you get that feeling that the patient's really legitimately been coerced into having a procedure, you as the patient advocate need to contact the doctor and say, hey, I'm not really sure this is a voluntary situation here. In home care, a lot of times I would deal with family members wanting to keep a patient home when it was long after they were safe to be home. Because it was financially beneficial to the family not to have mom, the widow, who's the sole owner of the house now that her husband has died, to go into a nursing home because they knew that the state would get the house. And that was their inheritance. So sometimes they would push for the mother to have more done, stay at home when it really wasn't safe for her to be done. So you really have to be aware as a patient advocate what's going on here when that patient signs the informed consent. When you sign the informed consent, what does that signify? What is your signature on it? That you witnessed the patient's signature. You are not verifying that the patient understands it. You are not verifying that the patient is of sound mind, that all this other stuff. All you are doing is verifying that this is Jane Doe and Jane Doe is the person who signed it. Now, if you feel that, that little old lady that you've been taking care of for the past couple of days and she barely remembers what her name is, and then you see her signature on an informed consent for a procedure that's not an emergency, it's an elective situation, you as the patient advocate need to call that doctor and say, this lady is not of sound mind. There's no way that she could possibly understand what is going on here. So as the nurse, you are really like that last wall between maybe that confused patient or that patient that's being abused by family. And then he comes into the hospital and the family is pushing for them to have all kinds of things done, and the patient really is kind of doing what the family wants because they're afraid. So you have to really be a patient advocate in this situation. Now, physician's orders. The physician is responsible for writing the orders, setting up the medical plan of care, and you have to follow the medical orders unless you deem that they are unsafe or not, not correct for your patient. Because if you follow those orders when you know that it could be harmful to your patient, you are just as liable for any harm that comes as the doctor is who wrote those orders. So you can't say I was just following orders. You need to be aware of the fact that maybe this isn't unsafe, this is too much, this is a med that the patient's allergic to, and there's nowhere on the chart that you can find that that allergy is, but you know from talking to the patient they're allergic to penicillin. Something's got to be done. You have to intervene as the patient advocate. So what is negligence, and how does that differ from malpractice? Anybody have an idea on that? What is negligence, and how is negligence different from malpractice? Yeah, Jesse.
Negligence is like ignoring the issues, whereas malpractice is doing something that you know is not correct.
Close, very close. Negligence, anybody can be negligent. Negligence is doing something or failure to do something that a reasonably prudent person in that particular situation would do or not do. So it's, you can be negligent texting while driving and running into a telephone pole. You don't have to be in a professional capacity to be, anybody can be negligent. When it becomes malpractice is when you have somebody in an official, licensed, professional capacity not following standards of care, doing something that is against what they have been taught, an unreasonable lack of skill, or improper or unethical conduct. So malpractice can only be done by a person who has a professional stature, a license, special training, and they fail to meet that higher standard for their particular profession. So lawyers can commit malpractice, doctors, nurses, anybody with a professional license or a career can actually commit malpractice. Yes.
We can never get an informed consent as a nurse.
Correct. Correct. You are not the person who gets the informed consent. The doctor gets the informed. The only thing that you would be doing is if the doctor has filled out that consent and has put in there everything that he or she has told the patient, and the patient signs it and you witness that signature, but it really should be the doctor that has that patient sign the informed consent in front of them. Now there's an increase in malpractice cases against nurses. And one of the reasons, when I first got out of nursing school back in the dark ages, they told us that we didn't have malpractice insurance when we were in nursing school. And they told us, don't worry about getting malpractice insurance. When you go to work for a hospital or a nursing home, their malpractice insurance, it will cover you like a big umbrella. And if something happens, they'll take care of you. And that was fine back in the days when they rarely sued nurses for anything that happened. They usually sued the doctors and the hospital because they had the deep pockets. And they were the ones that were to blame because they perceived nurses as kind of being, we were just going around following orders and we weren't thinking independently. But what do you think is going to happen if something happens to a patient and your interests as the nurse in the situation conflict with the interests of the hospital and or the doctor, and the only insurance you have is the insurance that the hospital has to cover you? Who do you think their lawyer is going to really work hard to support and protect, and who is going to get thrown under the bus? Yeah. So the malpractice insurance that you have now as students, just roll that over. Once you get your RN, roll it over into RN malpractice insurance and cover your butt. Most places now require you to have your own malpractice anyway. Pretty much every place that I work, even as a clinical instructor, I have to show proof of malpractice insurance. And once I got out into home care, that was a requirement for us as well. And the fact is that now more and more nurses are being sued, along with the doctor in the facility and everybody else that they could possibly think of to sue. First of all, nurses can be sued for delegating contrary to the Nurse Practice Act, and we're going to talk at length about delegation in this particular unit. But if you delegate a task that it is not lawful for you to delegate based on your Nurse Practice Act, even if your facility says, sure, it's okay, we'll let you do that. No. And harm comes to the patient, not only will the person you delegated that to be found liable potentially, maybe in a civil case, but you, as the person who incorrectly delegated, can also find yourself in deep trouble. Early discharge without appropriate referrals. You may be that discharge planner on the weekend in your small facility, and you have this little old lady who the family says, no, we don't want her to go to the nursing home, we want her to come home, and you know that the only person that's going to be taking care of this 80-something-year-old lady is her 90-year-old husband, who you have seen, barely making it from the elevator to her room when he comes to visit her, with his cane and or walker or whatever. And he's the only one that's going to be taken care of because the family just flew in from California to get mom settled and they're leaving tomorrow morning. And you signed off on that discharge without making any referrals to home care, or in this case, that I'm talking about, without calling the doctor and saying, look, this is not a safe discharge, and I'm not going to sign off on it because something can happen. The case that I'm referring to, something did happen. The little old lady went home, fell, fractured her hip, came back into the hospital and died during surgery. And the nurse was sued for an inappropriate discharge, for not making the appropriate referrals and sending that lady home to an unsafe situation. Now, if the patient and the family sign her out AMA, against medical advice, morally and ethically and in your heart, you feel horrible about it, but legally you're not liable if something happens. I mean, you can only do what you can do, and if people are determined and they're of sound mind and they want to leave against medical advice, they're going to do it, and there's nothing you can do about it. And in that case, you document, so that if anything ever comes back, it's like, nope, they signed this, and I have it documented that they signed out against medical advice. Nurses are getting sued because of mistakes that they make because of downsizing and short staffing. The busier you are, the more shortcuts you might be tempted to take, and I'm sure you've seen it occasionally in some of your clinicals, of nurses doing things that you were like, whoa, not really by the book, and that was a little scary, and or even questioning a nurse politely and saying, well, why, oh, well, this is the way we always do it, and you're like, whoa, not the way I'm going to do it, because the more shortcuts you take, the more risk you give to get sued, make a mistake. Advances in technology. When I started out in nursing again, back in the dark ages, glucometers had not been invented. Seriously. Patients who needed a blood glucose, the lab came up and did the phlebotomy. So the way we monitored our patients' glucose control and the way we taught our patients was doing urine dipsticks for sugar and acetone. The problem was it wasn't going to spill sugar in the urine until their blood sugar was over 180, so right there their control is not good. But then they came out with the glucometers, and the early glucometers were very complex to use. They were timed, and you had to wipe them with a cotton ball, and you had to wait, and you couldn't put the strip into the machine until it beeped 4 times, not 3 times. I mean, it was just, there were so many ways that you could possibly make a mistake and get an incorrect reading. So you had to make sure that you followed the directions, you did all the quality control checks, and you made sure that the reading that you were getting was accurate. Now, you guys are seeing, glucometers that, a minuscule drop of blood on the arm can give you the results in 5 seconds. Fingerstick PT-INR machines. When I first started in home care, we had to do phlebotomy, and by the time I left, we were going out doing finger sticks, get the INR, call the doctor from the house, get the Coumadin order, and be on our way. Made life a lot easier instead of having to draw it, schlep it to the lab, wait for the lab to call the doctor, go back at night and fix the Coumadin in the pill box because maybe nobody was there that could do it for her. Made life a lot easier, but if you didn't do the quality control, and some of the doctors still didn't like us using those finger stick PT-INR machines because they didn't trust them. So anytime you are asked to use a particular new piece of equipment that you haven't been shown, you need to make sure that you get the proper training, or you say, I'm sorry, supervisor, but I need to bring someone in with me that has used this piece of equipment before, and I'll be more than happy to go in there and learn how to use it, but I am not going to do it and risk the patient and my license in this situation. Better informed consumers, another reason why nurses get sued all the time. You can't turn on the TV, particularly late night, or when I was laid up with my foot surgery. I saw way too many, Mark E. Salamone and all other kinds of, John Hammond. If you took this drug and you had this minor side effect, you could get millions of dollars by joining this class action suit. People want a fast buck. They want, they want a perfect outcome, and if they don't get a perfect outcome, they want to make money on it. So people are more inclined to sue now. We had a case at a hospital I worked at one time that a patient that had had a lumbar laminectomy, back surgery, developed a wound infection. And about a month or so after he was discharged, we found out that he was suing everybody from the administrator of the hospital all the way down to housekeeping. Because he got a wound infection. And the reason he sued housekeeping because he said they didn't clean the sheets properly. But fortunately, we had documented throughout his 4 or 5 day hospital stay that he refused to have the linens changed on his bed. He refused morning, afternoon, and evening care. He didn't want us to change his dressing when we were supposed to. He was just laying like a lump in the bed until it was time to go home. And he got a wound infection and wanted to blame it on us. It never went to court, because we had documented so thoroughly that he had been refusing. We had gone and we were performing our standards of care, and we were doing what we were supposed to do, and he was refusing it. So you got to document the actual care given and sometimes the refusal of the care that you're trying to give in order to cover yourself. The expanded legal definitions of liability, a lot more nurses are becoming advanced practice nurses, APRNs, nurse practitioners. They have prescriptive authority. They can be primary caregivers for patients versus the physician being the primary caregiver. So with those expanded legal and the expanded legal definitions and the advanced practice comes a higher level of accountability. And so more and more nurse practitioners are being sued in cases where probably the doctor would normally have been sued. Yes?
Did you change the PowerPoints? It says increased autonomy and responsibility.
I thought I had put up a new one, but apparently not. What's that? Yep. Everything's gonna be changing in the fall again. Anyway, so there's 6 major categories of negligence. Ways that, again, you can have problems with getting sued. Being accused of malpractice, losing your license. Failure to follow standards of care. When they say, look at the policy and procedure manual, look at the policy and procedure manual. Because if you do what needs to be done according to policy and procedure, and something happens, you've got a much bigger leg to stand on. If you make a mistake, and everybody's human, but you have followed standards of care, you have done that complete admission assessment on your patient, which is a standard of care. You have followed the doctor's orders, as long as there, wasn't a problem in terms of, danger or, inappropriate. Following those standardized policies and procedures can be very important and can really save your butt in these kinds of situations. Failure to use equipment in a responsible manner, going back to what I just said about the glucometers and all other types of equipment, knowing what the manufacturer says has to be done, what quality control measures have to be done. In home care, JACO required us to document and keep a log of every single glucometer that the nurses had and how often we did the control checks, and there was a certain standard. So many times a month we had to do high-low control checks. And if they came in and when they were doing their audits and they found a glucometer that didn't have that log on file somewhere, that was a deficiency, that was a ding, that was a problem. Failure to communicate. Your patient's going down the tubes and you don't communicate that to the physician. So you need to notify the physician in a timely manner when there's a problem. Being able to recognize and report when things are changing and things are not going the way they should. Listening to complaints and acting on them. The patient says, there's a problem with that chair over there. I was sitting on it today and the leg seemed like it was loose. And you say, okay, I'll take care of it, and then 4 hours later, a visitor comes in, sits on the chair, falls, and breaks a hip. And the patient's laying there in bed. I told Pam that there was a problem with that chair. It's not your responsibility to fix the chair, but it is your responsibility to take something that's broken out of use and call the people that are supposed to be taking care of it. So a patient complains to you, it's your responsibility to do something about it, to act on it, even if it's passing that information along to the person who's responsible, so that they can never come back to you and say, well, I told you about it, and you go, wow, I totally forgot about that. Well, now we have a patient in the hospital with a broken hip, and here's your pink slip. See you later. Communicating discharge instructions appropriately, making sure the patient understands exactly what they need to do when they leave the hospital. Now, back in the bad old days before electronic medical records, you could barely read some of those discharge instructions they gave you in the emergency room. And if that's the case in the facility that you're working in, you need to sit there and go over those discharge instructions and rewrite them so that the patient can read them. I used to do that a lot in home care because the physician would fax over the the orders, and I would look at them going, I can barely read them, and I know what they are, so I'm going to rewrite them so the patient can actually read them and understand them and put them in language that they understand. So that's communication, huge. Failure to document. Now, you've been told from the time you got into Ed's class, if you didn't document it, you didn't do it. But then you've got the facility saying, okay, we're trying to reduce paper. We have this particular computerized medical record that you only have this tiny bit of space to put in everything that you want to say. So you need to learn and make sure that you're documenting clearly, concisely, just the facts, but everything that's important that has to go in there. Because again, they will still say if they subpoena that record, if you don't document it, you didn't do it. And you can't say, 5 years later, oh, I clearly remember, giving that Percocet at 2 a.m. to this patient, when, you can't really even be expected to remember the patient, let alone the Percocet at 2 a.m. Failure to assess and monitor. You are responsible as an RN to do that complete shift assessment. So when you come out a report, even though that may not be your priority, you've got somebody that needs to be seen right away, very quickly and very soon within that first shift, those first few minutes of the shift, you need to do a shift assessment. You need to make sure the patient's there. And those hourly patient checks, many of you may start your nursing career at night, on the night shift. And you will have, of course, more patients than the nurses do during the day. And those patients who are sleeping soundly and are not on the call bell are your best friends. Because you don't have to, you feel like, they're not demanding all my time. So you're spending all your time with those, 4 or 5 patients that are constantly on the call bell. They're having a lot of problems. There's issues. But you're still responsible for doing those hourly bed checks, making sure the patient is not only in the bed, but still breathing. And a nurse that I work with at Johnson was telling us this little story. She normally works the day shift. She got mandated to stay over late or to come in or something, and so she came in to do the third shift. And she got there at 11 o'clock, got out a report by midnight, and had like 7 or 8 patients, and she went out with her flashlight, and she said, I don't just peek in and make sure the patient's still in the bed, I actually walk over to the bed and shine the light on their chest and make sure they're breathing. And when she did that, the lady was not breathing. And so they called a code. She didn't make it. She was pretty much already dead. But think how embarrassing that might have been if at 4 o'clock when the tech went in to do the 4 o'clock, the morning vitals, and the patient was stone cold because nobody went in to do the hourly checks because, hey, she wasn't on the call bell and she wasn't bothering us. And I was running my tail off with this lady who had, get 4 units of blood and all this other stuff that was going on. So make sure you do your bed checks hourly. And this last one, failure to act as a patient advocate. If you do that, if you act as a patient advocate, all those other things are going to fall into place. So if your focus is acting as a patient advocate, you will make sure that your license is not in jeopardy, the patient's safety is not in jeopardy, and all those things are happening. You're following standards of care, you're doing assessments, you're using the equipment properly, you're doing everything that you're supposed to do because your primary goal is to be a patient advocate, patient safety, and the best outcome for that patient. So nobody wants to quit now, right? You still want to be nurses, right? Sure.
Not scared.
No, not scared. Whoops, this is out of order. Okay, I have a case study. 56-year-old female came to the emergency room complaining of lethargy, disorientation, slurred speech after a motor vehicle accident. It's not in your slides. 4 days ago, she was prescribed 4 milligrams of Dilaudid. This is a true case. 2 days later, her heart rate dropped to 20 to 30 beats per minute. She stopped breathing, leading to irreversible brain damage. The plaintiff, the family, claimed Dilaudid dosage was inappropriate, and that caused the respiratory arrest and the brain damage. They also said the nurse failed to record the noon dose of Dilaudid and failed to notify the physician when the plaintiff could not be awakened for physical therapy later in the afternoon. A different nurse failed to wake the patient at midnight and administered more Dilaudid, unaware that the Dilaudid had been given earlier. Now, the defendant said 4 milligrams of Dilaudid was appropriate, that the failure to document the noon dose was a harmless mistake, and the additional dose of Dilaudid was proper. So, who do you think won the case? The plaintiff. And what are the red flags that you saw in that scenario? No documentation of what? The noon dose of Dilaudid was never documented. What else?
No one documented that the state of the patient when they gave her another dose, that she couldn't be awakened.
Right. First of all, they couldn't wake her for physical therapy, and nobody saw fit to apparently give that information along. And then, do you ever give pain med to a patient who's sleeping? So that was a failure to assess and monitor. They didn't even wake up the patient. How can you document level of pain, where it is, describe the pain, and then the relief of the pain if the patient was sleeping when you gave it? And how many of you have seen patients that, the family, they're on a PCA pump, and the family's sitting there, and the family goes and pushes the button, Yeah, you probably saw it, yeah. It's like, no, the patient, it's patient-controlled analgesic, not family member controlled or nurse controlled. This particular case was won by the plaintiff, an $8.35 million verdict, 70% liability against the prescribing physician. 4 milligrams of Dilaudid is way too much, unless you've got a horse or somebody that's like 700 or 800 pounds. 2 milligrams of Dilaudid is pretty much the most I've ever given IV push to a patient. And then the other 30% went to the nurse who didn't record the noon Dilaudid dose, because that was kind of like the beginning of the snowball down the hill. Because by not documenting that, all other kinds of stuff went wrong. I would have thought that they should have also found against the nurse that gave the midnight dose of Dilaudid without waking the patient. And perhaps maybe in the civil suit nothing happened to her, but maybe her license got revoked. Because not only in these kinds of cases do you have the monetary issue of the civil suit, but then you get dragged before the State Board of Nursing in a public hearing and usually get your license suspended or revoked, depending on the severity. We have a 40-year-old female, status post-arthroscopic knee surgery. She claimed that post-op she was instructed to scoot down to the foot of the bed while the nurse held her leg and thighs straight, and when she reached the end of the bed, the nurse dropped her leg onto the floor, resulting in extreme pain. She also claimed that 10 days after her discharge, she was diagnosed with a ruptured quadriceps tendon, that subsequent surgical repair failed, and she had to have numerous surgeries over the next 4 years. The defendant said the incident never occurred. Now here's proving a negative. There was no notation in any of the plaintiff's post-surgical records of the incident, because of course if it didn't happen, you're not going to have documentation. But if it did happen and the nurse decided I'm not going to document it to cover my butt, so you've got, two potential situations here. The nurse says she doesn't recall the plaintiff or the incident in question. There were a lot of people that went in front of the Senate in the Watergate hearings, which most of you are probably too young to remember, that said they didn't remember anything that, I didn't remember that happening. They said the plaintiff's story was not believable because she would not have been placed on a bed following the initial surgery, but would have been in an orthopedic chair. She also claimed that the plaintiff did not complain of the nursing incident until 6 months after the surgery and after she had undergone physical therapy, so that it could have occurred when she was having physical therapy and not because of what happened to the nurse, something the nurse did. So who do you think won the case and why?
Nurse.
Nurse? Everybody think the nurse won the case? Why do you think the nurse won the case? What of that scenario?
6 months and she went to physical therapy.
There was 6 months.
Yeah, it wasn't enough, like, the clinic didn't have enough.
And there's no way the nurse would not just remember anything in 6 months that she had taken care of it.
It's very difficult to prove a negative, because if there wasn't something that really stood out to the jury in that case, it could just as easily have gone the wrong way. Because if she just said I couldn't remember and it wasn't documented, and they could have had a nurse expert from the other side get up there and say, this is the standard of care, and what makes you think that she doesn't remember, or what makes you think that she didn't just not document it because she was afraid she was going to get caught. The thing that really clinched it was her being able to prove that they followed the policy and procedure in the facility, that the patients did not come back from surgery on a stretcher, they came back in an orthopedic chair. They had proof of following the policies and procedures of the hospital, and that's what saved her. Because she was able to say it couldn't have happened because she would have never come back on a stretcher, she would have come back on an orthopedic chair. And that's what saved her. Because all the other stuff, the time that the jury could just as easily say, well, we don't care if it was 6 months. We don't care if she had physical therapy. We believe her when she says you dropped her leg and injured her leg. But because she was able to prove that they followed that policy and procedure, she ended up not only winning the case, but getting $5,800 to reimburse her for her out-of-pocket court costs, things that her insurance did not cover. 59-year-old female had elective knee surgery, went to the PACU, the blood pressure dropped, she went into respiratory arrest, she got Narcan, blood pressure went to 287/169, which caused cerebral edema and brain damage, and she died 4 days later. The plaintiff, the family, claimed that the physician was not called until 11 minutes after the respiratory arrest occurred. The defendants said they followed standing orders from the CRNA in administering Narcan, which is certainly, they were probably able to show that policy and procedure and the protocol that the CRNA, the certified registered nurse anesthetist. They also said that the patient had a rare adrenal gland tumor which caused a spike in the blood pressure, but the autopsy did not reveal any tumor. So what do you think the verdict was? The patient won. Why?
No tumor.
Because of the delay in the time they called, they should have called.
Everyone post up, you always call the doctor.
Because they lied about the tumor. And you get up on the stand and you lie about one thing, they're not going to believe anything else that you say. So $675,000 for the plaintiff's family on that particular case. 78-year-old female resident at a skilled nursing facility. Dizziness, nausea, no vital signs or labs taken. Next day she was found unconscious and bloody. Her daughter was told that she died of a heart attack. The chart had no mention of the bloody condition, but the autopsy said GI bleed, probably for several days. There were false chart entries. One of the chart entries was that she was given insulin an hour after she had been pronounced dead. So somebody's watch wasn't working. There were late entries, and there's nothing wrong with a late entry that's been identified as a late entry. You know, in the heat of the moment, you may forget to document things that happened in a situation, but you very clearly say that it's a late entry, and it should be written by the person who was actually on shift at the time of the incident. These late entries were written by people who weren't even on shift. Obviously, like a supervisor trying to clean up the chart before the chart got subpoenaed. So yeah, they were able to look at the payroll and the schedule and see that the people that signed these late entries weren't even in the hospital at the time. So you cannot document a late entry on something that you were not part of. You have to be there. So $54 million to the plaintiff, 4 million compensatory, 50 million punitive. 80% was assessed to the skilled nursing facility, the other 20% to the 2 nurse practitioners who were under contract by the skilled nursing facility to be primary caregivers for the patients in the facility. So lots and lots of stuff. So again, these are real cases, edited, for discussion purposes. So yeah, document. So now we're going to move into quality improvement. Now that we've talked about lack of quality, you know all about QSIN because you've had it since the day you walked through this nursing program. So who can tell me what the QSIN concepts are? Patient-centered care, safety, teamwork and collaboration, informatics, evidence-based practice, quality improvement. Okay, so there's a lot of issues with healthcare quality. I mean, that's all you hear about today with the healthcare bill and changes in insurance and people, dealing with, lawsuits, tort reform, all kinds of things. There's 2 big issues that we deal with when it comes to healthcare quality. There's the underuse of beneficial services that can cause problems with poor outcomes. What kind of situations would lead to an underuse of beneficial services, things that the patient would need to have done? Financial. Either the patient can't afford it or the insurance company won't approve it. And sometimes that underuse of beneficial services, that MRI that may have found that tiny spot on somebody's lung 6 months ago before it became a stage 4. Another problem, and probably more common that you see, is the overuse of procedures that are not medically necessary. Why do you think that happens? What's that? Yeah, I mean, for fraudulent purposes, physicians or facilities billing for things that maybe they're not even doing. Don't want to be sued. All those things that we just finished talking about, a lot of stuff is being ordered and approved by insurance companies because the physician wants to cover all the bases and make sure that they don't miss something that could come back 6 months later, that tiny spot on the lung that might have been caught 6 months ago, now it's a stage 4 and the patient is terminal. So now, the family could sue and say, okay, you didn't do that MRI 6 months ago. And in many cases, the insurance companies, although they may fight the doctor, a lot of times will cave and say, okay, do it or do this alternative because they don't want to be sued by the patient if a bad outcome happens and the only reason that the bad outcome happened was because the insurance company refused to authorize a test or a procedure that might have found what they were looking for. So quality improvement is going to be a big issue as we go forward with cuts in benefits, skyrocketing costs, because the more non-medically necessary tests that we do, the more the insurance companies are paying, the higher the premiums get. I mean, so it becomes a vicious cycle. And there's a lot of political talk about it, and there's a lot of political opinion. My personal opinion is, and you don't even have to subscribe to it, I'm just going to give it to you, if they have tort reform, if there is, so that people cannot sue for huge amounts of money for minor things, that's the only thing that's going to get the costs of healthcare. It's one of the probably primary ways that we're going to get healthcare costs under control, is to not make it so easy for people to sue, and then what'll happen is that the insurance companies will settle because it's cheaper to settle rather than take it to court. Because they know that they could get a jury that could give that $80 million verdict. And maybe in that case it wasn't so obviously the problem of that facility. So you may, in the course of your work, be able to work on a risk management committee or a safety committee in your facility, and using things like incident reports to track and monitor patient outcomes. Now, the old methods of quality improvement used to be they would wait until something happened that went wrong, and then they would try to find out who did it, and then so they could blame somebody. So what do you think was the problem with that type of approach to quality improvement? Waiting until somebody makes a mistake and then track down the person who did it and, you know, fire them, discipline them, or do whatever has to be done.
There's no preventative, it's just.
There's no preventive. Yeah, it's retrospective, it's after the fact. People keep repeating the same mistakes because maybe it's not that there's 5 stupid nurses on the floor that keep making the same mistake. There might be another problem in the system that's contributing to it. And what do you think might have been, you know, as you know, an unethical nurse that said, okay, I made this medication error, but nobody saw me do it, and there was no harm to the patient, nobody's going to know, so I'm not going to do an incident report because I'm going to get in trouble and lose my job. So things, again, would get shoved under the rug. Unethical, bad practice nurses would be getting away with stuff because it wasn't a huge, egregious error. They were able to hide it. And as Effie said, you know, if people are repeatedly doing the same mistake, then you need to know about it. And that's why now quality improvement is more of a prospective type of process. You look at the systems, you look at how patients progress through the healthcare system, how a medication goes from being ordered by the physician to actually getting up to the floor, to try to find out, okay, where's the breakdown in the system? You know, what is it that made somebody give, you know, instead of doing a saline flush, before we had pre-filled saline flushes, we would have to take the saline out of a vial, maybe a 10 milliliter vial, and gave them a potassium flush instead. Because the potassium in the saline vials looked so similar, the labels by the same manufacturer looked so similar, maybe a slight variance in color, and maybe the person who gave it was colorblind and couldn't distinguish red versus green, and gave potassium. Now granted, there is that whole aspect of, you know, you don't give the medication until you've gone through the 5 rites or 6 rites or 7, how many rites you guys were taught, because it changes every year. But, you know, you shouldn't have made that mistake to begin with. But what contributed to that mistake was the fact that they were stored together on the same shelf in the medication room. Or what happened with, what was it, Dennis Quaid had neonate twins, and they were inadvertently given a higher concentration of heparin than they were supposed to receive, and almost died. That nurse could have been sued, could have lost her license. They never sued her. They never took it to court. But, you know, it could have had, you know, it could have had really disastrous results, all because the 2 different concentrations of heparin syringes were stored in the same place, looked very similar, and it was U10 instead of U100. Again, it's your responsibility to read those labels, but sometimes there's problems in the system that contribute to the fact that you're stressed, you're short-staffed, you're busy, and a mistake gets made. So knowing what the problems are ahead of time and anticipating what the problems can be and fixing them before they become a problem, so that you can't sit there and go, okay, yeah, there's 5 nurses that are really stupid on this unit. No, there's 5 nurses who made the same medication error because there's a problem somewhere else. Because how could you hire 5 stupid nurses? Particularly when there's not a nursing shortage, theoretically. So any questions? Quality improvement. So we'll talk very briefly about some nursing organizations. Connecticut State Board of Nursing, those lovely people who issue your license, and also do the initial approval and the ongoing monitoring of nursing programs, and investigate and take action on complaints against nurses. So if you ever have the opportunity on a Wednesday, if you go to the DPH board website and find out their schedule, find out when they're having disciplinary hearings, and go in there and sit there and watch a disciplinary hearing for a nurse who's maybe having their license suspended because of diversion of narcotics, or practicing while impaired, or going back in after having gone through a 12-step program and now trying to convince the board to reinstate their license. It's an eye-opening experience, and will really really impress on you the need to make sure that you're very, very careful and you're following everything, policies and procedures, to make sure that you don't make those kinds of mistakes. National League for Nursing. They're the ones that write all those fun exams that you've been taking since you came into the program. But they're working with a lot on public policy as it relates to nursing education, certification of faculty, and education research. They're working very closely with the National Council of State Boards of Nurses, those wonderful people who give you the NCLEX, to try to revisit the whole idea of judging nursing programs based on their first-time pass rate. And the National Council is very, a lot of pushback on that. But every nursing event that I go to the NLN Education Summit every year, and it's a constant topic of conversation. Is that student, you're accredited by your state, you're accredited by whatever accrediting agency, whether it's the NLNAC or the AACN. You're doing everything that you're supposed to do as a program, and a student decides with 104 fever and meningitis that their mother said they're fine and they can go take the NCLEX, and they go take the NCLEX and they fail. Or they worked a double shift but they go take the NCLEX. So how much of that was the student was well prepared and made a bad choice versus blaming the program? So that's something that I know that Connecticut they're working on. They're talking about opening up the regulation in Connecticut and reassessing it to make sure to see if maybe they could look at first and second time pass rates, because the vast majority of students who don't pass on the first try do pass on the second try. It's rare that we see somebody go 3 or 4 or more tries. So hopefully that will be. You've got the American Nursing Association, which is kind of really a big umbrella. There's a state chapter for that fits under the American Nursing Association. There's a CNA in Connecticut. There are 2 in Massachusetts, because what the MNA, the Massachusetts Nurses Association, that used to be affiliated with the ANA, is now a collective bargaining union type of organization. And so another organization came up, the Massachusetts Association of Registered Nurses. So it's really important as you go through your career to join a nursing organization. It's great networking. People find out about jobs. If you're not liking the field that you're in, you can run into people that, that could possibly, give a good name for you. If you get into a specialty, after you've been in that specialty for a certain period of time, you can get certification in that specialty. Many organizations will require you to have a BSN in order to get certification, but the American Nursing Credentialing Center, which is affiliated with the ANA, does have some certifications that associate degree nurses can get. There's gerontology, I believe, med-surg, psych might be even one of them. But you really do need to, to get your bachelor's. I know it's not something you want to think about right now because you just want to get through this, but start thinking about it, by the time you get out and get your RN. So, any questions about what we already talked about? Legal, ethical, things like that. We're going to talk about prioritization of nursing care. Now, as I said last week or so when we talked about test-taking strategies, prioritization is huge on the NCLEX. Prioritization is also something very important that you will need to be able to do in order to function as a nurse. If you can't prioritize and you can't delegate, you will burn out 6 months to a year into your career. You've got to be able to prioritize and delegate. So what is prioritization? Who can tell me what that is?
Put most urgent things first.
Right. What has to be done first? Being able to identify what's the emergent, what has to be done first, what can be delayed if it's not urgent. So what are the things that you have to take into account? The 4 Ps of prioritization. The purpose. Why are we taking care of this patient? What's going on? What is the purpose for all these tasks that we have to do? So what do we want as our outcome? What else? The big picture, the clinical picture. The patient's acuity. And when we talk about prioritization and they ask you on an NCLEX question, or you come out of report and you ask yourself, who do I need to see first? Who's my priority? There's certain things that you have to think of that are going to help you prioritize, that we talked about when we did test-taking strategies. The length of time that has elapsed from when that patient had a procedure, like a surgery or a test. Extremes of age. Certain, things like when, patient's lethargic, floppy, all those kinds of, kind of buzzwords that kind of indicate that that patient is in serious trouble. That's your priority. And then the third P is the plan. Now that you've figured out what's the purpose for the patient's care, what's the clinical picture, how acute are they, okay, now what's my plan? How am I going to get these tasks done in the proper order that's going to be the best outcome for that patient, the safest outcome for that patient? And what's the fourth? The part. The role that is played by each person on the healthcare team. This is where we get into delegation. If that LPN, can that LPN or that CNA take care of some of these tasks, some parts of the plan of care that are not a priority, that are legally allowed to be delegated? And how are you, as the RN who's in charge, going to get everything organized and planned out and prioritize the care for your group of patients? So you have to think about what can happen, what can go wrong if I don't go to see this patient right away, or if I don't do this task right away. Do I have time to get this task done? Or do I have to delegate it to somebody who's authorized to do it? Or will it take me so long to explain what needs to be done that it's best that I just go and do it myself? What can happen in terms of safety for other patients on the floor, or the nurses, or the other staff on the floor? So how can I prioritize my care in order to make sure that everybody is safe, including the patient, and the job gets done, and I'm delegating and organizing this legally? So we're going to review again the ABCs. We talked about airway, breathing, and circulation. So that patient who's a really severe respiratory condition is going to be your first priority. Maslow's hierarchy, those physiological issues that are going to take a much higher precedence over, I know I need to do discharge teaching for this patient, but I've got to go assess the patient on the vent first. The steps of the nursing process, getting more information before you start doing something. Not just running in and doing a medication or a procedure without first doing that assessment. So we have a newborn arriving in the nursery with APGARs of 1 and 4. Pick up your clicker and tell me, what is the priority intervention? Collect the resuscitation bag to oxygen, turn on apnea and cardiac monitors, prepare for insertion of an IV with D5W, set the radiant warmer control to 97.5. Okay, 93% said resuscitation bag to oxygen, 7% said apnea and cardiac monitors. Why did 97% of you pick the resuscitation bag to oxygen? Airway and breathing. You need to make sure that that patient, because APGARs of 1 and 4, now it's been a long time since I've studied OB nursing, but I kind of remember that that's not good. Right, so patient's got to be bagged. Then you're probably going to turn on those apnea and cardiac monitors and start the IV and all that other stuff. But they're not asking you to put it in order of priority. They're just saying, what's your priority? And that's connecting the resuscitation bag to the oxygen. What's the most immediate concern of the community health nurse for the potential needs of a group of homeless clients? Peer support through structured groups, setting up a 24-hour crisis center hotline, ensure adequate food, shelter, and clothing, find affordable housing. And 100% of you were concerned about adequate food, shelter, and clothing. Nobody wanted to set up a 24-hour crisis center hotline?
Not before the food, shelter, and clothing.
Why? Maslow. What's the priority nursing diagnosis for the child with a history of juvenile rheumatoid arthritis? Disturbed body image related to activity intolerance, potential for self-care deficit related to immobility, high risk for injury related to impaired physical mobility, acute pain related to inflammatory process. Okay, 7% potential for self-care deficit, high risk for injury. 86% said acute pain. How come you guys didn't like high risk for injury? Safety, isn't that an issue? It's a risk for. So acute pain is going to be your priority. Why? It's an actual nursing diagnosis. It's a concern with the disease. It fits with the situation. And it's physiological versus psychosocial. The client received a thermal burn caused by inhalation of steam. His mouth is edematous and you notice blisters in the mouth. What's your priority assessment? Temperature via rectal route, respiratory status and lung sounds, neurological status, level of consciousness. Is this real? What? Are they too easy? He said rectal temp. Everybody knows that. 100% said respiratory status and lung status. Don't you wish all your questions were that easy? Okay, here's one. The nurse manager has just returned from vacation. It's the beginning of the shift. Which activity will he or she attend to first? I want to be politically correct in terms of the number of... Yeah. Crash cart that needs checking, client assignments for the day, a phone message that the charge nurse for the next shift is ill and will not be reporting for work, a stack of mail from the education and administrative departments. I love when this happens. I love it. Crash cart, 40%. Client assignments, 40%. Phone message that the next shift charge nurse is sick, got 20%. I'm going to go back so that we can see. Okay, so why is number 3 not our priority? Let's eliminate that one first. What? It's the next shift. You're going to have to deal with it at some point, but it's the person who's coming in the next shift, and you just got here at 7 o'clock this morning. You know, you're going to worry about 3 o'clock, you know, a little bit later. And nobody cares about the stack of mail, right? You know, most of the time you're going to end up throwing it in the trash. So half of you said the crash cart that needs checking, and the other half primarily said client assignments for the day. So crash cart, advocate for that.
I would say she could delegate that to somebody else to check.
Could delegate.
Let the client do more work.
What's that?
Someone could crash at any time, so you need to check. If it needs checking, meaning like...
Because usually the protocol is it's got to be checked either once a day or once a shift.
Client safety code.
Okay, client safety. So why did an equal number of people say the client assignments had to be done first?
Who's going to work on the patient?
Who's going to work on the patients?
But someone's already going to be assigned to those patients.
No, you're the charge nurse. You just returned from vacation. You're the one making the assignments.
Right, but there should be someone that was already working the shift beforehand that's going to have to...
But that's not, you're reading into it. In this particular case, it's there, client assignments for the day. That's something that she has to do. That means that nobody put up the assignment for the shift. Jeremiah. Right. Client assignments have to be done. If somebody codes during report, can you do CPR without the crash cart? Yeah. So, yeah, you need to check the crash cart. You could delegate it, but it kind of, the question kind of implies that she doesn't have anybody she can delegate it to, or he doesn't. So, but the client assignments come first because somebody has to be taking care of that patient, be in charge of that patient. So when they fall on the floor, it's not like the waitress that flies by and says, not my table. You know, when you say, can I get some sugar, or, you know, or can I get some cream, or can I get another cup? Not my table. Not my patient. Now, you know, people wouldn't do that, but in reality, your priority is making sure that every patient has somebody assigned to them so that if something does go wrong while you're checking the crash cart, somebody's in charge of that patient. So number 2 is the correct answer. Patient is showing signs and symptoms of a hypoglycemic reaction. Put the following in order of priority. So you can't use your clicker for that. So what's the first? So you've got your options, and you will get some questions like this on my exams. You're going to give the patient 4 ounces of OJ, obtain a blood glucose level, document, determine the cause of the reaction. So what are you going to? Excuse me. What are you going to do first? Do number 2, assess, gather more data, find out. They're showing signs and symptoms of a hypoglycemic reaction, but you don't know for sure. You need to gather more data, assess, and you're going to need that data because if in fact they are low, you need to be able to say how low they are, and then give them the orange juice, right? Because you got to get that blood glucose before you give them the orange juice. Then what are you going to do? Determine the cause. You got to find out, if you can, or figure out what might have caused it. Asking the patient questions, what were you doing, what did you eat, when was your last insulin, all that kind of stuff. Find out, try to get some more data about what might be the cause of it, and then document. So the last thing in this case is writing it all down. You want to make sure that the patient is in fact having a hypoglycemic reaction. Give them orange juice. Then talk to them, try to find out, you know, what they were doing, what they ate, what they didn't eat, when their insulin was, what med they're on, whatever. And then when you're all done with the incident and you've gone to the tech and said, hey, go back and check Mrs. Jones's blood sugar in about a half an hour and see if we need to do anything else. You know, I just gave her some orange juice, keep an eye on her, and then go document. And probably call the physician too, but because you only had 4 options. Okay, here's another one, put in order of priority. You've just taken report on these 4 clients. Place them in order of your assessment priority. Pulmonary wedge resection 1 day ago with closed chest tube drainage system. Ulcerative colitis scheduled for discharge. Admitted overnight with severe exacerbation of asthma. Scheduled for a KUB to locate a kidney stone. 3, why? Right, it's airway, but pulmonary wedge resection is airway. Just admitted, acute exacerbation of asthma. You've got somebody that could go into respiratory distress real quick. And if you're the RN, you may need to do an admission assessment if they were just admitted. And then what? Then 1, because again, it's a respiratory, but it was a day ago. He's got a chest tube, and there's no other information, so you can't say, well, what if there's an air leak? Well, you know, it doesn't say that in the question. Then what? Yep, you're going to, that patient that's going for x-rays, because you may need to do some teaching. If he has a kidney stone, may need some pain medication. And then what? Patient going home, who's probably standing by the desk saying, I need my papers, I want to go home, but not your priority, although they'll try to make you think that it's your priority. Okay, we're going to stop here. We're going to do delegation on Wednesday, and also, if we have time, which I know we will start respiratory. So bring your Iggy, because you will need it to do an activity in class.